Okay, thank you very much, Drew. Thank you to this great audience. It's just a delight to put on the first Lymphedema Symposium. I agree with everything that was said by the previous four speakers. Can I go home? But I'm going to actually give you a different take on and a different twist, because my core value is not the environment. I had to work in a hostile environment. My core value is not relationships. I had none. And plan, I had a bit of a plan. So let's go back to the year 2002. And we're starting a lymphedema clinic at Beth Israel Deaconess Medical Center. There are very few, if any, such entities in the world or in the United States. None that I knew on the East Coast. I had a colleague, Dr. Stanley Roxon, on the West Coast, who was starting a clinic at about that time. And we had to start from scratch. My core value was resident education and the resident as the center of this lymphedema universe. And I believed that if I could stimulate residents and trainees, that the program would collect around them. They were going to be the center of the universe. So let's see how this looked and how it actually worked out, if it worked out. I have no financial disclosures. I wish I did. Okay, so we go back to 2002, and I have a core of Harvard plastic surgery residents, and I decide I'm going to start this clinic, and the hospital says no. But I'm still going to do it because I have an outstanding mentor named Dr. Robert Goldwyn. And I tell him, Bob, hospital's not giving me any space. And he says, if they give you a closet in the basement, that's where you'll see patients. Okay, we got something very similar. We start the clinic, and people come, and we do have referrals from, thank God, occupational therapists and physical therapists, and they are truly our best friends. And cases begin to come in, and the residents start to be stimulated intellectually by what they're seeing because they hadn't seen any of this before. And one of them says, I'm beginning to learn a lot from this lymphedema clinic and center that you're starting. And he reviews the patients, and he writes our first paper describing the types of patients that we have coming in and what types of diagnoses they have. And his name is Dr. Evan Garfine. And Garfine continues to be interested in lymphedema throughout his residency, finishes his training, goes to New York, continues to treat patients with lymphedema, and he's currently the chief of plastic surgery at Montefiore at Albert Einstein. So I feel like I'm off to a decent start. I've stimulated one of my residents. He's continued his intellectual interest. He's doing studies, publishing papers, and a program is growing around this core value of resident education and academic productivity. Let's continue the journey. The next is a paper on similar patients, noticing that they all have different diagnoses when they come to us, and that most of them, or a substantial fraction, have the wrong diagnosis and have been put on the wrong medications. Almost a third are on diuretics. We point this out in the paper. Now, lymphedema is actually a disorder that I think would stimulate any doctor and anybody who cares about patients. It's very debilitating. It progresses in many cases. Unfortunately, we have no cure, as has been stated repeatedly today. And it's frustrating to doctors because they don't know what to do about it. So, if the lymphatic system is a black box and a definite entity of ignorance, then we, the residents, and we, the faculty, have to do something about it. And that's a challenge that I think was taken up by the young plastic surgeons here. And so, why would plastic surgeons be interested in this problem in the first place? And why are they particularly suited to be the leaders in the treatment of this population? They all have been educated in extremities and hand surgery and anatomy of those parts. They understand the microsurgical anatomy of blood vessels and the orphan of the vascular system, the lymphatics. They're interested in breast cancer because we want to reconstruct patients who've had lumpectomy, partial mastectomy, and other types of mastectomy. They know how to do liposuction. They learned it back in the 80s when it became popular. They know how to treat deformities from birth, and they also are experts in dealing with problems that result from other treatments such as radiation therapy. So you have the core person that you want. You want a young plastic surgeon, and you want them interested in this problem. And now you have something that you can work with. And so cases begin to come into our lymphedema clinic. It's 2002. I have dark hair. That's how long ago it was. And the residents are seeing these patients, and they're wondering, well, what can we do about these swollen limbs? Can we do microsurgery? Lymphovenous anastomosis has been done. Can we do liposuctioning? Hasn't gained worldwide recognition, but Dr. Borson has already been doing it for 20 years. And can we do types of excisions that could help these patients? So they're stimulated, and they want to do suction-assisted lipectomy on the lymphedema patients, just as they're hearing about it coming from Sweden, and they think it's a great idea. They also want to begin to focus on the lower extremity, which did not get the attention of the upper, even though the majority of cases in the United States are related to breast cancer, and are particularly upper extremity from that point of view. So we begin to look at legs, and one of my residents, L&RN, looks at this entity, and we call it the fat leg syndrome. We're not trying to be insulting to anybody. We're talking about swollen legs, and they have a broad variety of etiologies and diagnoses attached to them. And so now I have another resident, I actually have two, who are willing to look at all of the different diagnoses and establish a differential diagnosis of how to separate these entities. This is sorely needed because there is terrible confusion in the field. We don't know who has venous disease, who has other reasons for having lymphedema besides lymphatic disorders. So we start looking at legs, and we realize that there are quite a few diagnoses that are appropriate. Now we want to study it, and some of my residents are saying this would be a good laboratory project. And we're going to look at animal models, and am able to convince some of them to try to create an animal model using rodents. And as I mentioned earlier this morning, one of my residents would go over to the Dana-Farber Cancer Institute, it's only across the street from Beth Israel, and worked in the lab creating a rodent model using rats. And we were able to establish with surgery and radiation therapy to the inguinal region, you could establish stable lymphedema. And once you had stable lymphedema, you had a matrix to work on various treatments. And the residents are excited about this development, and they want to do more. And so it carries over into the lab over at Mass General, where we went every Sunday into the radiation biology lab because it was made available to us. And I and 2 or 3 of my residents worked there developing mouse models. And one of the people who worked with me was a young PhD candidate interested in molecules, but fascinated by lymphatics and how they functioned and the physiology of lymphatics. And that was Melody Swartz. And she wrote 2 or 3 papers with us, and she finished her PhD, and she is now the Ogden Professor of Molecular Engineering at the University of Chicago. And so I'm beginning to see that this concept of building your core value around the people that you want to educate has tremendous opportunities because the relationships, the environment will form around them as the central, most important piece. This is another paper that was written by Melody and by Albert Luskin. Albert Luskin was a Harvard medical student in his last year, and he was fascinated by this concept of an animal model and the tram flap. And so he studied it with us and also looked at suction-assisted lipectomy for the lower extremity. Before I come on to Aaron Green, let me just mention Dr. Luskin went on to Emory University. He finished a plastic surgery residency. He's currently professor of surgery at Emory, and he is head of the plastic surgery training program. So now I have reached the second generation, and I have people who started with me in lymphedema, and I see that they're achieving their goals in the field of education, and the programs are developing around them. They are my core value. Now, Dr. Aaron Green, who spoke this morning. Aaron also completed a residency with us. He loved the lymphedema clinic. Not all the residents love the lymphedema clinic. In fact, I had to make it mandatory because some preferred to skip it, but we weren't going to let them get away with that. And as much as I love the residents, certain things have to be done. So Dr. Green was very interested, and when he finished, he took on a job at Children's Hospital across the street, and he's now the director of the Vascular Anomalies program and director of the program for lymphedema at Boston Children's. And Aaron has been extremely productive. As a result of his support and collegiality, we were able to write our book in 2015 that I am proud of. And we began to look at the problem of obesity that I alluded to this morning. And we noted that if your BMI is over 53 and getting up to 60, you will have lymphedema even if you had no other reason to have it and you had no surgical cause. So, looking at this group of patients, we noticed that there was a definite relationship between BMI and lymphedema. And we're quite happy that the New England Journal of Medicine was equally interested in this concept, and they published our paper. There were other offshoots from this concept of concentrating on your trainees, stimulating them intellectually, encouraging them to do the work that would lead to advances in lymphedema and would ultimately lead to the creation of the lymphedema centers that you've been hearing about today. So lymphocele, a problem that we noted in patients getting medial thigh lifts. And again, a different resident was interested in this and is now practicing in plastic surgery and continues his interest in this problem. So I could show you some others, and I'll flip through some more. And these are all written by my residents, but I want to concentrate on one of the all-time favorites. Dhruv was a Harvard plastic surgery resident. He passed through the lymphedema clinic at Beth Israel. He maintained his interest. He and I had numerous discussions about the future of lymphedema. He went on to study in Taiwan with the great people that have spoken today from that country. Started a program in Florida, in Gainesville, and was a perfect example of stimulate the individual and the program will develop around them. And the environment will develop around them and the relationships. And Dhruv is now head of our lymphatic surgery program here at BIDMC. So my pitch to you is education of residents is extremely important. Let's try to intellectually stimulate the next generation, and what a great future we will have in this area. Thank you.